Thank you so much for being with us today. It's an honor and great pleasure. My name is Khalil Al-Salem. I'm going to talk about advances in muscle plication or tucking versus resection. As we all know, muscle resection has been there for half a century now, and it carries some risk. One of them, for example, is the slippage of the muscle, and it's very painful, as you can notice after waking up the patient. Most of them, they are screaming from the pain. So I converted to plication like 5 years ago, and muscle plication implies folding on the muscle itself and fixing up the muscle to the sclera. This is called plication. Now, in case of a tuck, you fix the muscle to the muscle itself, like the proximal part of the muscle itself, rather than fixing it to the sclera. What are the advantages of muscle plication? I noticed a lot of advantages. One of them is that it is virtually painless. Most of the patients, they wake up and they don't have pain, which is really great after the operation. It reduces the risk of muscle loss, or muscle loss is virtually not there. Most of the studies documented that it doesn't disrupt the blood supply. It is as good as resection, as nominated by many strabismologists like Dr. Reich. And it really reduced the time of the operation, like in my hands, by half. And there is no need for cautery, since I didn't notice a lot of bleeding. I did a very small series of around 48 patients, and the patients were almost split between plication and resection. 27 muscles were plicated and 21 muscles were resected. The follow-up period was 5 years, and this is a single surgeon study. The average deviation was 32 XT for the plicated group and 38 ET. Resection, the preoperative average was 28 XT and 36 esotropia. After 5 years, most of the patients are ortho with a small amount of phoria, which was insignificant. I had to go back and redo 2 patients over the 5 years time in the plicated group. However, in the resection group, the redo was around 1 patient. The p-value were insignificant regarding the deviation. P was 0.8, and the p-value for the redo cases comparing the 2 groups was also insignificant. P was 0.67. So what is the technique? Simply, the muscle is stretched after exposing the conjunctiva and tenon, and then you pass an absorbable stitch at a regime which is comparable to resection. Okay, once you put the needle in the belly of the muscle, you go and lock it from the ends, and I'll show you the way they do it. And after that, you get an assistant who will fold the muscle for you, so that you can safely tie the muscle and anchor it to the sclera. And that's the technique. Right, passing the first stitch, you pass it through the belly of the muscle, and then you go back, and then you go through and through, locking the muscle from one end, and you repeat it in the other end, as you can see here. However, I improved my technique by putting a running stitch over the muscle again. This really improved the outcome, and I didn't have to do any redos after doing this technique. The thing is that it doesn't really harm the blood supply. It doesn't. I didn't notice that it does cause a lot of pain post-op, but it really anchors the muscle more to the sclera, and your plication is more successful. Correction of A and P pattern with plication is very feasible. You just fold the muscle and put it at the same point where resection is done, and you can do half tendon width or full tendon width when correcting A or V pattern. Finally, I use something called Wright's mini plication, which is a beautiful technique for convergence insufficiency. You know, those patients that, you know, come and go to your clinic, they have a very small exophoria, less than 9, and you start them on prisms and they're unhappy. But with the mini tuck, it really solved a lot of those patient's problem. And conventionally, I tuck between 3 and 4 millimeters, depending on the amount of phoria that I have. And then I fix the belly and the center of the muscle fibers to the insertion. And that's it. According to Dr. Wright, it's an office-based procedure, but I don't prefer doing it at the office. I usually do it in the operative room because I don't do local anesthesia for my strabismus cases. Is it reversible? Plication might be reversible in the first couple of weeks, but I've never actually tried reopening a plicated muscle. Adjustables, I'm not a big fan of adjustables. However, the literature is full of cases where muscle plication has been adjusted by many patients. And I really thank you so much for your time. This is my barcode. I'll be very happy to contact you if you need anything. And thanks for listening.